On-the-scene coverage of ACC 2015 is supported by Effient.
I'm Peter Block in San Diego at ACC 2015 for On the Scene. This is the third day and this is the wrap-up. On my left is Deepak Bhatt, my friend and partner in crime, as I said yesterday. We do the wrap-ups and we are wrapping up a lot of information from this ACC 2015. We want to talk about today, the first thing will be ablation versus amiodarone for atrial fibrillation. Your thoughts on that one, Deepak?
Well, I think it was a pretty clear win for ablation. So some had been skeptical exactly what the value of ablation was versus amiodarone, but I think the trial was a pretty clear-cut victory for ablation.
Absolutely. I mean, this is the short version, but that's really the short version that makes a lot of sense.
Right.
So amiodarone loses big time. An interesting sort of sidebar on this one is that Mark Gilinoff presented today a surgical side of this where he showed that with mitral valve surgery, regardless of what for, mostly regurg, left atrial ablations really minimized the resultant atrial fibrillation at 1 year. And it didn't make any difference whether he did venous isolation or whether he just did ablation of the right and left atrium. So again, a winner for ablation.
Yeah, and I think that's a particularly important study because in the field of cardiac surgery, there have been a lot of AFib ablation performed without a lot of high quality data. So this is very useful.
Yeah, so we're learning a lot about both sides of the atrial fibrillation story, surgical and medical.
Right.
So let's move on. Here we go. For those interventional cardiologists out there, routine aspiration during PCI. Do you do that?
Well, I do it. I was senior author of a meta-analysis that supported doing it, but the data have spoken.
No question about it. It turns out, I think, that aspiration is dead. Now, having said aspiration is dead, this is for routine PCI and acute coronary syndromes. When I did the interview about this story, I asked the question, really, aren't there some patients where there is a lot of thrombus burden and you try to open with a balloon and nothing really happens where you wouldn't reach for the thrombolysis catheter or the aspiration catheter? And the answer is, I think judgment still prevails here.
I think so. And in the total trial, which is the trial we're discussing, even in the control arm, about 7% or so had gotten aspiration thrombectomy. So there's some patients where big mobile thrombus, I think many people would still reach for manual aspiration, but certainly as a routine strategy, this trial, following the previous TASTE trial, shows you shouldn't do it routinely. And in fact, in this trial, there was also a signal of excess stroke. Small signal, but it was there.
That is correct. So I think we can say maybe we won't see any more of those trials. That would be a good thing. We've seen enough of those.
So.
All right, Matrix, you're into your court.
Okay, well, I actually thought it was a terrific trial, about 8,000 patients or so, factorial design, randomization to radial versus femoral approach, and also randomization of bivalve versus heparin. And it was a win for radial access. I say that with some trepidation because I know your interpretation's different, but the overall primary endpoint was negative by the statistical standards set in the trial. I have to concede that. But there was lower all-cause mortality in the patients randomized to radial versus femoral, which I thought was interesting, and of course there was less bleeding.
Yeah.
But you're not buying it, I know.
Well, I buy it because I think bleeding's not good for you.
Sure.
And, we've seen a lot of trials now where we have radial versus femoral, and they all come out that there's more bleeding from the femoral side.
Right.
I get that. But and I also get that bleeding isn't good for you, and probably that's what pushed that mortality statistic more than anything else. I don't think you kill more people by doing a femoral than you do doing a radial, but it's the bleeding issue that carries with it a bad thing that we don't really quite understand that isn't good for patients.
Agreed.
And I still think that if I were in trouble with cardiogenic shock and need for multiple devices and so forth, I still like the femoral approach because maybe it's just because I'm comfortable.
Well, see, but that's a big part of it. I think for folks that have done thousands of femorals as you have, there is a certain speed and comfort with it, and especially if you do need large devices, it's hard to beat a big femoral artery. The other part of the Matrix trial had to do with the bivalve heparin, which has been a big source of controversy with, HEAT PCI, then the BRIGHT trial. It seems like every meeting, every trial, there's a bit of flip-flop about which one's better. But here I thought a pretty clear win for bivalve.
Absolutely. Bivalve wins very easily here. And Now again, when are we going to stop seeing these trials of heparin versus bivalve? But this one now flip-flops again. The last one was heparin, and everyone said, gee, maybe it's cheaper, maybe it's better, let's go to that. Now here we are with bivalve again.
Right.
We'll probably see another trial.
Well, I'm not, actually there is one other trial that's going on that's a big trial. I believe in the Swedish registry they're doing a big trial still of bivalve. So maybe there's more to come.
Okay, but for now, bivalve wins, certainly for the radial approach. Okay,
Right.
So we have one trial that I think is really extraordinary, and that is the after 80 trial. This is acute coronary syndrome STEMI in patients that have age of greater than 80,
Right.
randomized to conservative versus non-conservative invasive therapy. I'll let you tell the answer.
Sure. So, non-STEMI, unstable angina, about 400 or so patients randomized into an invasive versus conservative strategy. Now, this question of invasive versus conservative has largely been answered in younger patients, but in octogenarians, it's an open question. And the trial very decisively showed a reduction in the primary endpoint, including components of the primary endpoint of myocardial infarction, as well as, of course, urgent revascularization. But MI as a standalone endpoint was also very significantly reduced, large degrees of risk reduction. So I think the trial very definitively showed that if you're in your 80s and you have a non-STEMI or unstable angina, you ought to go to the cath lab, maybe even more so than if you're a younger patient.
Well, this is a critical trial because up until now, I think all of us have said, well, really, look at all the calcium, these are old people, comorbidities, et cetera, et cetera. But the fact is they do a lot better. And as we were talking before, I remember 100 years ago when patients who were above the age of 70 did not have coronary artery bypass graft surgery because they didn't do as well. But
Absolutely.
Now everyone who is 80 gets coronary artery bypass graft surgery, an aortic valve replacement. TAVR has changed our thinking.
You're right. I think TAVR has done a lot to change our thinking about what is old. Where does it actually kick in that somebody is old? The term elderly sort of falling out of favor.
Yeah, but then again, there is always the old patient and the old patient.
Right. There's chronological age and biological age.
So clinical judgment still prevails, I think, from time to time whenever you're dealing with somebody who's in their mid and late 80s. But if you do something, the data show the patients do better.
I mean, 80 is the new 70, right?
There you go. 80 is the new 70. With that, we'll leave you, and that's the wrap up for day number 3.